I'm on live now. Please go ahead. You are on mute, ma'am.
Very good afternoon to all of you. I'm Shutapa Biswas, the co-founder of the Cancer Foundation of India. On behalf of ASSOCHAM and the Cancer Foundation of India, it's an absolute pleasure for me to welcome you all to today's session. Well, April is the Head and Neck Cancer Awareness Month, so we took this opportunity to reach out to all of you. To get us started today, we are pleased to have with us Commander Navneet Bali, Co-Chair, ASSOCHAM Healthcare Council, and Regional Director North, Narayana's Super Speciality Hospital, Gurugram. Commander Bali has served the Indian Navy for almost 30 years before he ventured into the healthcare industry in India. He has been the Group COO and Head of Business at IOSPL, Unit Director of Rockland Hospitals before joining Narayana Health. In his current role, he is responsible for overall strategic planning, operations management, service excellence, and business development in the northern region. Commander Bali is a Master's in Finance and BSc from the Jawaharlal Nehru University. He has undergone multiple professional trainings in finance and management from institutions such as the Edinburgh Business School, Scotland. Thank you, Commander Bali, for being with us today, and over to you.
Thank you so much, Sotapa, for this introduction. Delighted to be here today amongst luminaries, experts, surgeons, and we also have Jan joining us. So welcome, Jan, and thank you for being here in addition to everyone who's here. I think it is very, very important for us to discuss, deliberate, and maybe not essentially provide solutions, but maybe think about certain things that could be done in short, medium, and long term, and look at ways in which we at least brainstorm over this very, very important topic, especially in India, because as we are aware, about 60% of global head and neck cancers occur in Asia, and most of these happen in India. And also, 1/3 of every cancer patient in India is a head and neck cancer patient. It's about 30% of all cancer cases. But what actually makes the situation a little bit more, difficult and little bit more tragic is that around 80%, 70 to 80% of these patients who suffer from head and neck cancer come in very, very late stages for treatment compared to around, let us say, 35 to 40%, in the Western world. Added to this, the strata of economically backward people or people who are from the poorer sections of the society, they because of lack of education, lack of facilities, and other socio-economic issues, suffer from this cancer because we have seen basic things like tobacco chewing and other factors. And the worst part being that many times, even when they have symptoms, they either are afraid to go to medical centers or don't want to go because it leads to lack of employment. It leads to lack of, and he or she might be the only wage earner for a family, which makes the situation a little bit more difficult. What we have seen is because, Narayana Health runs a lot of around 20, 23, 24 hospitals in India, and most of our hospitals have comprehensive oncology centers. Dharamshila is one of the most famous cancer hospitals in India, being in Delhi. So we have seen that many of these patients are very reluctant. Even we have seen when they come to the hospitals and are detected and people tell them that, we would like to start this treatment. Many of them don't come back again. Many of them just, vanish. Many of them don't, follow up. So it is such a tragedy, it is something that, first of all, we are coming late to the hospital for treatment. On top of that, you are not wanting to get the treatment because you know that it will be economically such a burden. And some research, I was just reading some paper that the out-of-pocket expenses for many of these poor people who hardly can afford, three meals a day, is huge. And you can imagine that the family has to decide, and it is such a big tragedy. The second thing that we found was that we talk a lot about preventive oncology. We talk a lot about coming early or testing early. There's a psychological barrier which people have because they feel that if you test, then it's quite possible that something will be revealed. And and many times we don't talk about it. You see, we have been talking a lot about preventive oncology. We talk about a lot about doing camps in these places. We talk a lot about people coming and showing, let us say they have a small abscess or something, come and show doctors. And so we talk about it that, we tell them, we educate people that earlier you detect a cancer, the better it is. But just the simple fact that when you will be tested, there's a likelihood of something coming puts a psychological barrier. So there are huge number of issues, especially head and neck cancer, because of the state of the society, because of the scourge that it carries, the economic burden that it carries, and also, coupled with that, the prevalence of tobacco from a young age itself in villages, in small towns, and the awareness, even if it's there, but it is somehow shrugged off because, smoking a hookah or putting tobacco in your mouth, small children, I mean, that is again, such, what should I say? And I mean, it starts at the early age. So by the time you are grown up and you start earning, you already are into this habit, deep into it. So there are multiple issues, there are multiple level of problems, there are multiple things which need to be done, and it is such a humongous sort of situation ahead of us. And there are very great, I mean, people sitting today in this panel itself who have done a lot of work around this. There are people who have actually gone deeper into the, and I'm sure people who are participating today, they would love to hear, what actually is happening. Are we looking at some kind of a light at the end of the tunnel? I mean, there are doctors who are here. Dr. Kaushal Yadav himself is a practicing doctor. He has operated on these patients. He understands, what goes on, what kind of treatment it is, how difficult it is for the family to come to terms. So, cancer anyway has got multiple economic, psychological, physical issues in the family, issues in the society. And I think we wouldn't have found a better panel to discuss this. So I will now, sort of take a break. Hand over to you, Sutapa. Thank you very much for inviting me today. And I wish that these webinars or these interactions, all of them lead to knowledge sharing. All of them need to little bit of improvement in what we have been doing so far about addressing the situation. As I said in the beginning, the solution is not, it's not an absolute thing, it is not a stopover. It is something that is a direction that we go towards. And I'm sure today's webinar also is a very important step towards that, trying to do something better tomorrow than we are doing today, and to help, sort of, thank you very much for inviting me. Thank you, sir. Over to you.
Thank you so much, sir. I think you put the entire issue in perspective. Yes, we should do something better tomorrow. So whatever knowledge we gain today, we should be able to apply it in our lives. It is not just how much we know, how much we do, I think is more important. So we are all set to go straight to the subject. So in the next hour, you will hear a fantastic panel of experts covering the key aspects to control head and neck cancers and their prevention. But the question is, why are we talking head and neck cancers? Because it is in the list of 5 major cancers in India, as Commander Bali said. It is highly preventable, but we aren't doing much. So it makes sense to talk about it. So to begin the discussion, today I would like you to hear a video message from a very special person. He couldn't be with us today because of the distance where he is, and connectivity is an issue. So Pandit Arun Kumar. He has faced oral cancer, got treated, recovered, and is now a champion for the cause. Can we please have his video message? It's wonderful. We wish him great health and active life. Well, talking of cancers of the head and neck region, it is not one cancer. Primarily, the oral cavity itself has multiple parts that get the cancer. The tongue, lips, gums, cheek, palate, and added to it are the voice box or larynx, throat or pharynx, nose, salivary gland, and the like. But what triggers this cancer? Does it happen on its own? Do some have increased risk? What does one do if they get cancer? To answer all of these questions, we have 4 subject experts today. And if you have more, please put it in the chat box. I'll have them taken at the end. To lead us into the subject, we have none other than Dr. Prakash Gupta, a celebrated epidemiologist and an eminent public health researcher in the field of tobacco control. Dr. Gupta is an absolute authority on the subject. He has spent a lifetime since 1966 building Indian evidence on tobacco use so that professionals across the country can refer to it. Dr. Gupta is the director at the Yearly Sexaria Institute of Public Health, Mumbai, since its inception in 2004. Prior to this, he was a senior researcher at TIFR and an honorary consultant at Tata Memorial Hospital in Mumbai. He's a guest faculty in several international institutions, including Harvard. He's an advisor to numerous NGOs, including ours, across the country. He peer reviews over 20 research journals, provides strategies to governments, and the list is endless. He's a DSc in epidemiology from Johns Hopkins University, was a Takemi Fellow of Harvard, and a visiting scientist to IRWHO, among many other recognitions. What an honor for me to introduce you, sir. Then we have another dynamic leader in tobacco control, Professor Ravi Mehrotra. He is yet to join us, but he'll join in a while. He's the founder, Center for Health Innovation and Policy, CHIP Foundation, New Delhi. Professor Mehrotra is a dynamic leader in the field of tobacco control and cancer prevention in India. He's an MD, DPhil, and FRCP who excelled in every sector he worked in, starting with oral pathology and eventually emerging as one of the strongest advocates for tobacco control in India. He has provided leadership as director of ICMR's National Institute of Cancer Prevention and Research, NICPR, at Noida, and has been the founder CEO of ICMR's India Cancer Research Consortium, ICRC. He also established the WHO Knowledge Hub on smokeless tobacco at NICPR, which continues to generate data relevant to India. His excellence in leadership is well recognized. He received the prestigious Dr. P.N. Wahi and Dr. Lackman Awards in cancer prevention and the Ernest Fernandez Award of the Indian Academy of Cytologists, in addition to being its past president. Thank you, Professor Mehrotra. I hope you join in soon. And then we have with us Dr. Kaushal Kishore Yadav. He is a young, bright cancer surgeon with an experience of over 10 years. He's a senior consultant and clinical lead at the Narayana Specialty Hospital at Gurugram. He is an MS Surgery from PGI MS Rohtak, Haryana, and MCH Surgical Oncology from Tata Memorial Hospital, Mumbai, which is one of the apex hospitals for cancer care in Asia. He has acquired wide experience in cancer surgery from some of the best hospitals in India, TMH Mumbai, Max Hospital, Fortis, and Paras Hospital. Thank you. We are honored to have with us Dr. Yang Ping Lui is joining us from Singapore. Dr. Liu is currently the Global Director of Medical Affairs at MSD, where she provides leadership to the head and neck cancers within immuno-oncology portfolio. She has played several key roles in MSD for over 11 years. Dr. Liu started her career in clinical practice, followed by research and clinical development after graduating with a medical degree. She obtained her Masters of Science and Masters of Public Health subsequently. Prior to joining MSD, she served as a regulatory consultant with the Health Sciences Authority of Singapore for 8 years. Dr. Liu has 6 years of experience in immuno-oncology, focusing on various tumors, including head and neck cancers. Thank you all for being with us today. It couldn't have been a better panel, as Commander Bali had said. I think we have the best with us today. Thank you so much. So let's get started. I'll start with Dr. Gupta. Sir, from you, we would like to get the big picture of head and neck cancers in India, and of course, the primary risk factors. So you have to unmute yourself.
I was muted. I'm sorry.
Yes.
Okay. Thank you very much, Sutapa. I want to now share the screen. So do I have the screen share rights? Share. How do I share? This is share content button is there. Is that the one that needs to be clicked?
Ritika?
Because I haven't used this software
Yes.
before. It's mostly Zoom and
So
Google
the right
Meets.
has given to you. Please show
Okay,
your
now it
screen.
is there. Now
Yeah.
it is there. Yes, right. Okay. Mhm. Sorry, this is the wrong one. Is my screen is shared now?
We don't see the content.
Don't see
Do
the
see a
content.
screen.
How I do that, because this
Ritika, can you help, please?
yeah.
We can't see the PPT, but we can see the list of files. That part is visible.
No, that is a wrong one. I clicked first, then I deleted. I mean, then I closed it, so that should not be visible. But now, how do I?
Or else you can keep it open at your end and we can hear you speak.
That's not very satisfactory. In
I
fact,
know.
in fact now I can't even
Professor Mehrotra, good afternoon. Thank you for joining, sir.
show grid view and hide video view. Show active speaker. Sorry. I'm sorry. Can I email that to you, Sutapa, in a minute?
Not to me.
Immediately?
Yeah,
Ritika,
you can email it to me, sir. I will play it on your behalf.
Ritika Mehrotra. Do I have your email address, Malhotra?
I'll WhatsApp you my email address.
Please do that.
Yeah, sure.
okay, while we are at it, we have been joined by Professor Ravi Mehrotra. And so we are honored to have you with us today afternoon. So we'll just have Dr. Gupta speak. Once he is done, then we'll take on your session. So you're on mute. Yeah, Professor Mehrotra, you're on mute.
Yeah, while we're getting those slides, I had to beg off from another meeting, I'm afraid, from the WHO. This just went on and on, so I apologize for being late.
It's fine. You could join, which is great.
Yeah, I have Ritika's address.
Okay. And the good thing is now this is even daytime for us. Otherwise, this would have been about 3 in the morning in the US where
You
I'm
would have shifted the time then accordingly.
Oh, no, I don't expect to do that. There's so many others here. Thank you. It's very kind of you. So I was hoping to come in just as Dr. Gupta was finishing, but I think fortunately things are getting a little bit delayed, but I'm sure the wait is going to be worth it.
Ritika, do we have the PowerPoint?
I think it will take few
Or-
minutes for him to send it.
If you want,
We
I
can
can
move it to
actually
the next
start if
speaker,
you
I
want.
think. Yeah.
Yeah. Is that okay with you, Dr. Gupta?
Yeah, so Tapa ma'am, we can take the next speaker. Then we will play the PPT of Mr. Gupta.
There was a flow, so I would have liked that we have Dr. Gupta done. Then it will be easier for us to link it up to what Professor Mehrotra has. So that is what we would have liked.
Yeah, Dr.
My
Gupta, I have sent you a WhatsApp. Please check it.
I sent you already my PowerPoint. and your email on your email address. That was copied in Payal's email.
Okay, that helps. Maybe you could check your mail, it might be there already.
So, Ravi, you are back in USA?
Sir, I'll be going back next week.
Next week.
I'm in Delhi right now for the last 3 weeks actually. I come for a month. We've been trying to play telephone tag. Unfortunately, we're
Yes,
using up
unfortunately, it has not worked out. Yes.
I think today, after this meeting, we must definitely connect. It's been a very long time. I'm missing talking to you, sir.
Dr. Gupta, if we can start the introduction.
Sure.
Oh, okay.
Yeah.
So I think Ritika. Oh, great.
Yeah. Okay.
I think it's well timed.
No, I think
So we
Papa,
can
that was a very good decision because one kind of a get segue into.
Okay.
All
Thanks
right.
very,
Great.
yeah. Thanks
Dr.
very
Gupta,
much,
over to you.
Sutapa. And I thank ASSOCHAM for organizing this webinar. Very important topic, of course, and at appropriate time, head and neck cancer month or week. In fact, the main message, what I want to give, has already been given by the patient himself. And that message, as you know, is very, very powerful because it comes from heart, from emotions, with emotions, and from suffering. And what I say or anybody else say would come from science and data and reviews. But still, I think we require scientific evidence for everything. So I continue with my presentation. Next slide, please. It has already been said that head and neck cancer is a phrase that comprises of many cancers, which are put together generally from surgery point of view. The most common among a head and neck cancer is oral cancer. And that is a cancer with very specific documented etiology. So in this talk, I will deal only with oral cancer, not with other head and neck cancers. Next slide, please. Now, it has already been said by Commander Bali very clearly that there is a very high incidence of head and neck cancers in Asia and particularly in India. And that is an observation that has been there since late 19th century. And British surgeons who noticed this high incidence of oral cancer working in India, especially South India, they also noticed this unusual practice of betel quid chewing, which was very unusual for them. And they attributed high incidence of oral cancer to this practice. There is a seminal paper on this topic, Oral Cancer in Betel Nut Chewers in Travancore, its etiology, pathology, and treatment, that was published by Ian Morrison Orr in the Lancet in September 1933. So you see, the knowledge on this topic is not something new. We know it for quite some time. In fact, Orr reported a case control study in his paper. Perhaps the first case control study on any topic that I have come across, and it showed a strong dose response relationship. Next slide, please. Now, it is now very well established. There is plethora of evidence, data, tons of data that tobacco use in any form causes oral cancer. And we all know that the most widespread form of tobacco use all over the world is cigarette smoking. The fact that cigarette smoking, in addition to causing cancers and many other diseases, also causes oral cancer is very well established. Many times, I think many people forget that. in the plethora of case control and cohort studies reported from the world over, they are not just from India, the risk of mouth cancer from cigarette smoking has been significant and substantial with a strong dose-response relationship that confirms the causal hypothesis. In the IARC, International Agency for Research on Cancer, is a body of WHO that reviews all kinds of evidence for carcinogenicity. So in the handbook volume 11, it evaluated the risk of reversal after quitting of smoking. And it was found that the risk of oral cancer progressively reduced after quitting of cigarette smoking. And after 25 years of quitting smoking, the excess risk for oral cancer nearly disappeared. So that is a kind of a good news that, if you quit cigarette smoking, the risk will almost disappear after. It will take time, but it will keep on reducing and then disappear. Next slide, please. But in India, we know that cigarette smoking is there, it's common smoking, but the most common form of smoking is BD smoking. And almost all studies on BD smoking are reported from India because BD smoking is common in India. And whichever study has looked at the risk of BD smoking with oral cancer has shown significant and substantive risk for oral cancer. And these studies also demonstrate strong dose-response relationship, that kind of confirms or substantiate causal hypothesis that BD smoking is causing oral cancer. Now, BD smoking is a specific problem of India. And in addition to other cancers and diseases, it definitely causes oral cancer. So, on the whole, about BD smoking, there are so many misconceptions in the population, even among our policymakers, that it's a kind of innocuous product, used by poor. Tobacco is wrapped not in the paper, but in the tree leaf, and it's an unprocessed form of tobacco. But the fact of the matter is that BD smoking is at least as dangerous for health, perhaps even more dangerous than cigarette smoking. And all this research has come from India, and most of it until that time has been covered in a monograph, BD smoking and public health, that has been published by the Ministry of Health and Family Welfare, and it's available online. Anybody can download the whole monograph. Next slide, please. Now let us talk about oral cancer and smokeless tobacco products. As you know, tobacco is used in a wide variety of ways, and in India, use of tobacco in the form of smokeless tobacco products is very common. It's the most common form of use. And smokeless tobacco products are there in a wide variety of the ways. And we often many people mistake that smokeless tobacco use is only a problem of India. But that is not so. Smokeless tobacco is used all over the world over, in a wide variety of ways. I mean, it's about 80% of the use in South Asia, about 2/3 of the entire global use in India, but it is there in many parts of the world. The use is most common in India with a variety of products and variety of ways of using them. And this differentiates it from other forms of tobacco and use at other places. The smokeless tobacco products in India can be manufactured. Can we go back? Can be manufactured in large scale industries, can be manufactured in small scale industries, medium scale industry, can be manufactured in home industry, in home itself, can be made by a vendor. And even a user can make tobacco product himself or herself for using it right at that time. So there is a wide variety of products and wide variety of use. I'm on the next slide.
Next.
Okay. So now these products can be used in different ways. They can be chewed, put in the mouth and chewed. They can be sucked, just put in the mouth and sucked. They can be applied on gums and teeth. And there is one product in northeastern part of India, tobacco water, that can be gargled also. You can put in the mouth, gargle it and spit it. Tobacco can be used through nasal inhalation also, nasal snuff. It was common at some time in the past, long back in the past, but it is much less common now. And there's a global report on smokeless tobacco and its effect on health that is published by the National Cancer Institute, and that is also available online. Next slide, please. Now, since there is a huge variety of product, what the studies that report on oral cancer do is they put all those smokeless tobacco products together. So in any review of, if you review the studies from different countries, then again, we have to combine smokeless tobacco as one particular factor. The first review by the International Agency for Research on Cancer on Carcinogenicity of betel quid was evaluated for volume 37. Separately from other smokeless tobacco products that were also evaluated, and that was on way back in 1984. And in the final evaluation, the evidence was evaluated as sufficient for carcinogenicity of betel quid with tobacco as well as smokeless tobacco. And in IR parlance, having sufficient evidence implies causal association. One can say that this product is causing cancer. So smokeless tobacco and betel quid with tobacco causes cancer. That was established, in fact, long back. Next slide, please. Next slide, please. Now, before that, now the evidence for carcinogenicity of smokeless tobacco was re-evaluated by the IARC in volume 89 in 2007 and for betel quid in volume 85 in 2004. The evidence for carcinogenicity, and there were many new studies, that's why it was re-evaluated. The evidence for carcinogenicity was again evaluated as sufficient for betel quid with tobacco as well as smokeless tobacco. But a new development in these evaluations was, with the availability of many new studies, was that evidence for carcinogenicity for betel quid without tobacco was also evaluated as sufficient. And the active ingredient we know in betel quid without tobacco is areca nut, supari as we call, or slightly different names in different parts of India. And the evidence for carcinogenicity of areca nut was also evaluated as sufficient in the same evaluation. Next slide, please. And I am not showing purposely too much of data. I am an epidemiologist, totally data-driven person. But in this presentation, I'm not showing too much of data because not quite sure how much the audience would like that. But this is just a one table that I'm showing. It shows meta-analysis of 61 studies for risk of oral cancer from smokeless tobacco use. And you see, for all WHO regions, the effect size is 3.53 with very tight confidence interval and p-value less than 0.01. For Southeast Asia, risk is even higher, effect size 4.44. For males, it is high. For females, it is still high, and there are enough number of studies. And if you take individual tobacco products, like betel quid with tobacco, which has pan, areca nut, lime, and tobacco, the risk is 7.18, quite high. Oral snuff 4.18, gutka, which is very common, although only 4 studies, still the risk is 8.67. Manpuri tobacco, that was reported long back also by Professor Wahi, 3.32, and unspecified mixture of all these products also show significant, highly significant effect size. And the meaning of this effect size is that, for example, if in Southeast Asia it is 4.4, it roughly accounts to 344% higher risk compared to no smokeless tobacco use. So one can see how high is the risk from smokeless tobacco use for oral cancer. Next slide, please. So tobacco use in any form is the most important causal factor for oral cancer. Now, there may be other factors that are mentioned in scientific literature for causing oral cancer. Some of them are alcohol, human papillomavirus, oral hygiene, sharp tooth surface, and there are few other factors also. Alcohol use among them is important, especially because of the synergism with tobacco. When it is combined with tobacco, the effect can be higher, the effect size. But all other factors completely pale in comparison to tobacco. So even when you read about other factors, for oral cancer, they are not very important or very significant. Next slide, please. Now, I gave you all the depressing fact about causing oral cancer. Isn't there is a less depressing fact? Yes, if a tobacco user stops using tobacco, the excess risk accumulated due to tobacco use starts coming down almost immediately, but it takes a long time. And this has been shown in behavioral intervention trials in India. Those exposed to behavioral intervention for stopping tobacco use, they lowered their risk. And intervention helped significantly in stopping tobacco use. These are studies from India that have given these findings. Next slide, please. For reducing tobacco use, individual will is obviously most important, because unless a person wants to stop tobacco use, there is no way anybody else can stop tobacco use for him. But if an individual wants and does not succeed only through the individual will, there are behavioral intervention techniques that can help. These behavioral intervention techniques, they can range from very simple advice by doctors or dentists at the time of examination or other complaints, to intense intervention by counselor, taking various steps and various follow-ups. But if that is also unsuccessful, then there are pharmacological interventions that help. There are nicotine replacement therapy, as well as there are other medicines, pharmacological preparations that can help in stopping tobacco use. Now, all these techniques are individual based. But how we can help the whole population, because the problem is really with the whole population also. Next slide, please. The populations are affected by public policies for reducing tobacco use. There are several evidence-based public policies for reducing tobacco use in the population. Some of them are price policies, increasing the cost of tobacco products, e.g. through higher taxes, ban on advertisement of tobacco products, pictorial warning labels on tobacco products, showing the real effect of tobacco use on a person. No smoking in public places. And there are many more such public policies. Next slide, please. So these policies are enshrined in the first International Treaty on Health, the Framework Convention on Tobacco Control. India has ratified this treaty very early and has done quite well, reasonably well, in imposing many of the tobacco control policies. But there are many things to do still. It's not that we have reached at the end. For example, we still have to work on plain packaging, vendor licensing, tackling social media, internet, and OTT platforms for their tobacco production, tobacco promotion, disallowing designated smoking areas. So like that, there are many other things that still need to be done as public policies for reducing tobacco use. Next slide, please. So in conclusion, I can say that the problem of oral cancer in India, a most common cancer, can almost be eliminated by removing just one risk factor from the population, tobacco use. So it's obvious that we all need to and must work towards that. Next, please. Next slide, please. Thank you all very much for your attention.
I'm not letting you go. I have a couple of questions. That you were talking of a lot of tobacco forms that are there. Is there any which is the safest?
Very good question, Sutpa. This gets asked many times, and in fact, it was first propagated by the tobacco industry when they started with filter cigarette by calling it safer cigarette, and that sort of fooled also many persons. But the fact of matter is there is no tobacco product that is safe, so there is no question of any safer product. So all products are risky, they are dangerous product. The level of risk may differ slightly from one to another, but that is like, we often say, that is like saying whether falling from 40th floor or 20th floor is less dangerous than other. So it's like that. Even everything is so dangerous in tobacco, we really don't want to talk about one product being less dangerous than other product.
And how about e-cigarettes? It is said that, e-cigarettes are comparatively safer.
E-cigarettes are comparatively safer in the sense they have lower risk. If a person completely changes from cigarette smoking to e-cigarette smoking. But what has been found is that dual use is very common. Those who even shift, they continue to use both, and then there is no benefit at all. The second most important point about e-cigarette is that wherever they have been marketed, they have been marketed to young person, and adolescents and young adults have taken that e-cigarettes in a very big way. In fact, I have in India, fortunately, must congratulate our ministry for that. They have already banned e-cigarettes. But in the Global Adult Tobacco Survey, when the question was asked about e-cigarette, whether you are aware of e-cigarette and whether you have used it even once, much higher proportion of very young persons were aware of e-cigarettes, and even using once, they were the ones who have used. So, it's not there for reducing the risk, it is for increasing the risk among non-users, because it is not a safe product in any way.
We'll have more questions. I'm sure it'll keep coming, so I'll take it from the chat. I just couldn't resist asking these questions. But thank you so much, Dr. Gupta, for putting in the data for us in a simplified form. And we do understand that tobacco indeed is harmful, which I think is kind of embedded now in everybody's mind who heard you. And we need to understand that if we stay out of it, we can keep head and neck cancers away, primarily oral cancers, as you said. Thank you so much, sir.
Thank you.
That takes us to Professor Ravi Mehrotra, who will enlighten us on the screening and prevention of head and neck cancers. Sir, you're on mute.
Yeah.
Yes,
it is
thank you.
actually the term for the decade. Yeah, thank you so much for having me here to CFI, ASSOCHAM, and all the organizers here. I was just trying to, if we can, I very briefly will show you a few. I will not show you a lot of slides. I will not show you a lot of data. It will be more of just some pictures. Is that okay with you? So can I get permission to share, please?
We have a bit of a tech issue, sir. So probably will not be able to get the PPT on. So.
All right. So I think if that is the situation, what we will do is...
Yes, the right has given to you.
So then
all right. Thank you so much.
Yeah.
I appreciate it.
Thank you. Thank you, Ritika.
You are sharing your screen, right? Okay, fine. So I'll just go on to full screen. Yeah. Okay, can you see this?
Yeah.
So first of all, thank you for inviting me. I'll be as quick as possible. I will know we would like to have questions and answers rather than didactic talks. Dr. Gupta and our previous speakers have already talked about what is the extent of the problem. As you can see very clearly, head and neck cancers are sort of #1 cancer, especially in male in this country. And obviously, I will be talking again with Dr. Gupta. I'll be talking about oral cancers specifically. But we talk about the Globocan, there were nearly 1.35 lakh cases in this year, in 2020, roughly 10% of all cancers. And when we talk about prevention, which of course is the most important, and that's the main topic for the day, and thank you for bringing that up. The 4 kinds of prevention, which we talk about, the most important is primordial, that the risk factors. Secondary, the primary is health promotion, secondary is early diagnosis, and then tertiary is looking at disability, limitation, and palliative care. A reduction in tobacco, areca nut, and alcohol already been talked about. various other minor elements may or may not be important, and also whether curcumin has a role or not, that has also been controversial. But I think the main thing is tobacco, alcohol, and areca nut. Many people in India or even medical personnel do not really know so much about areca nut, and that I think I'll be talking about a little more in detail than others. Many of these diseases are preceded by potentially malignant lesions, and of course, these can be detected early. And again, through public education and screening, the most commonly used method is visual examination, which is simple and it is freely available, doesn't cost a lot of money. Risk factors I already talked about. These are some of the other ones, which I will not go into any details, but I would just mention about poor oral hygiene and prolonged risk exposure. Both are important as far as India is concerned. Symptoms, again, variety of symptoms, started from blocked sinuses to pain in the neck, as well as difficulty in speaking. These are the various methods of oral cancer diagnosis, which again, I will not go into details. We have used many of them, but for all practical purposes, that is used in real life in most places, including recommended by the Government of India, which I'll talk about, is oral visual examination. Talking about the second part from prevention is the screening, which of course is the secondary prevention. WHO says that the identification of unrecognized diseases or defects by means of test examinations, a strategy to detect a disease in an individual who does not have any sign or symptoms. So if you have a symptom, that is not screening, that is early diagnosis. There can be three kinds of screening: organized, targeted, and opportunistic. And some of the pioneering studies are actually done by none other than Dr. Gupta, who published way back nearly about 30 years ago in 1980s. When they talked about arnaculum, we talked about nearly 36,000 tobacco users who are actually screened using visual examination. And that is how they actually examined the feasibility of training the basic health workers. And that is where we found the association of tobacco with cancers, and at that time called pre-cancers or potentially malignant lesions. This was a 10-year follow-up study in Ernakulam in Kerala, house-to-house survey, and this reported an intervention group that once you stop or decrease tobacco, there's a decrease in leukoplakia, which is again a potentially malignant lesion. Then Dr. Shankar and his group from the IARC did this Trivandrum trial, which was the largest trial so far, in which they talked about a 15-year follow-up of 35-year-old individuals. I will not go into the details of this study. I'll just compare it later. And again, they did a house-to-house survey using high school pass students, and they found there's a 38% reduction in oral cancer prevalence and more than 80% in mortality in tobacco and alcohol users. And the other big study was done in Taiwan, which is between 2004 and 2009, in which they did about 42 lakh individuals biennially. And there they did screen detected cases, interval cancers, and non-attendees. When you compare the Kerala study and the Taiwan study, the Kerala was a cluster randomized control study in 35 years plus, while Taiwan was a population-based study in 18 years plus study. And screening done by health workers in India and dentists or physicians in Taiwan. So at the end of the day, what are the results? They found that in Kerala, as I mentioned, there was a reduction in both in incidence and mortality, especially in heavy users at the end of 3 or 4 screening rounds. In Taiwan, they found a 17% reduction in incident oral cancer and 20% in stage 3 and 4. They were downstage. There have been limitations, there have been criticisms, but these are the two main ones, and both were heavily responsible, especially the India study was the first one, and that was really responsible for showing the importance of oral visual examination and screening. And in 2013, our organization, the Indian Council of Medical Research, along with many workers and experts, including Dr. Gupta from HELIS, WHO, CFI, and a variety of other organizations got together and helped the government make the operational framework for management of common cancers. And that started off with the National Cancer Early Diagnosis Program of the government, in which, as far as oral cancer is concerned, there were people aged between 30 and 65, examined every 5 years by surgeons and dentists, and that is still ongoing as we speak. Now it is gathering some speed, hopefully after the corona. The work was done by the awareness by the ASHA workers. The A&M did the visual examination and specialists confirmed, and this information was later on sent to central data processing system. This again is the same diagram, the algorithm which we talked about. I will not bother about going into details. This is the specific thing. You find a visual abnormality, what do you do? What are the challenges? I think that's the most important thing. Lack of resources, awareness, shortcomings of various methods were obviously there, and huge amounts of data is going to be there. We have to make sure that we actually, this is appropriately organized, and also making sure that the funding and finances are there in the long run. So in summary, the aim for India should be to practice primary prevention, both at the primordial as well as the awareness level. Make sure we have early diagnosis to reduce the head and neck cancers, which at present come to between 60 to 80% in advanced stages, to at least 40% or less, as is there in many developed countries. Thanking you. So I would love to answer any questions as we go along. So Sutapa, I hope that was short and sweet as per your request. But I thought just since mainly there were pictures, I thought it would be a good idea to actually show it in a visual manner. It will be more interesting, and the way the image can be easily and the message can be easily given to our viewers. Thank you so much.
Thank you, sir. Actually, there's so much. That's what I was looking at, that, you've tried to put in a nutshell, both Dr. Gupta and you. I think that's one side of this oral cancers, which is the prevention part of it, screening, the guidelines. And many people always question that, is it harmful? Is there enough work done? I think the two of you put it together very nicely. And thank you so much for that. And we'll take the questions at the end. And now we come to the real world on the other side, where those who are facing cancers, what happens? We have with us Dr. Kaushal Kishore Yadav. Dr. Yadav, I have a couple of questions for you. That you see cases in the hospital every day, right? Almost every day of head and neck cancer, since you specialize in that. What is it that you think should be looked into when people come in for those treatments? And what are the means of management of these cases?
So thank you all for giving me this opportunity to put forward my views and my experience of managing these cases. So when these patients of head and neck cancer usually have the disease, they initially tend to delay the treatment, and they initially tend to delay and deny the fact that they have cancer because of some fear or some stigma. This is the reason that we are getting most of the patients in either stage 3 or stage 4. So initial most common symptom is that they have some ulcer in the oral cavity which is not get healing, and in our part that they tend to do some medicines, self medicines, or some sort of treatment, but it is not getting healed. Then they come to the doctors. Very few patients comes in early stages when they have some suspicious, some says that yeah, we should, doctor, please have a look, we have some kind of problem and it is not getting healed. Some patients even come when they are not able to open their mouth because of the reactions or trismus, which is called as produced by the cancerous growth, and the tumors which are in the throat or voice box or the larynx. They produce change in the voice. Uh, Initially, it is difficult to recognize the change in the voices when you are staying in a family, because it is gradual. But this is sometimes because of some change in weather or other factors. So even in those cases, we are getting the patients which are usually in the later stages when there is a significant change in the voice. Sometimes it also happens that the primary tumor is very less and it doesn't produce any effect, but instead there is some swelling inside the neck. So this is a, you can say, kind of lymph nodes from which drains the lymphatic fluids and cancerous cells from the tumor, and this swelling in the neck keeps on increasing, and there is no other symptoms apart from that, because the primary cancer which is producing these may be very small or sometimes even may not be noticeable. So gradually these swellings got increased, and people have perception that they may be because of tonsillitis or some infections, but these are also very dangerous because if they increase significantly, they can compress vital structures within the neck region. So these are the usual symptoms with which the patients present to us. So we have done a lot of work on screening also, but in real world, it is not practiced so much. So we need to educate the people much more about this. And when these presents, if they present in early stages, the treatment options are that they require very less treatment options. Usually surgery is curable in early stages of oral cancers and no further treatment may be required in very early cases. So financial implications and results are also very good. But if, as I said, they usually present in stage 3, at that time, the treatment is usually multimodality and financial implications are also more and treatment duration is also long. So in case of oral cancers, the usual treatment and is that they should be they should get surgery done. Surgery is the mainstay of the treatment for oral cancer, and when the cancers are usually in the throat part, then the usual initial treatment is for the preservation of the organ because of voice production and others. So in early stages, radiation therapy has a very good curative role in case of head and neck cancers or throat cancers. So when this tumor grows beyond a level that it destroys the framework of voice box or so bulky that even breathing or even framework or taking food is also difficult, then in those cases surgery is mainstay of the treatment even for the throat cancer because organ is also not functioning at that time. So basic principle of curing is that whenever we do surgery of any part of head and neck cancer, we try to remove it completely with a certain margins. And we also check during surgery with a technique called frozen section that all the margins has been cleared. And along with that, the draining lymph nodes within the neck are also removed, even if there is no detectable tumor in them on any imaging, because they may harbor some of the microscopic cells also. So purpose is to remove the disease completely so that patient achieve a good curative results. So as this part of oral cavity and larynx, these are very important in swallowing and the speech. The improvement which has happened is that rehabilitation and plastic surgery and reconstructive technique makes the morbidity of these kinds of surgery very less. Now we are reconstructing with free flaps and other advanced techniques. Even for the voice box, we have tracheoesophageal prosthesis and other modalities so that voice can be rehabilitated. Rehabilitation is also as equal part in this management. So you can see, you have also seen in the video of the patients, that patient, we have done the surgery that half of his mandible and maxilla, which is the, you can say half of the jaw has been removed and it has been reconstructed with by taking a bone from part of leg, and it has been reconstructed in such a manner that they have nearly as good quality of life as they have before the surgery and minus the cancer. So our purpose is that patient have good cure rate and they should live a life which is self-dependent and without any morbidity and attain to normal lifestyles as much as possible. And in cases when there is advanced, they require adjuvant treatment with radiation therapy. Radiation therapy is also considered as a curative mode of treatment in case of head and neck cancer, especially in case of throat cancers. When initial part we don't offer surgery for organ preservation, at that time radiation therapy has a very curative role in case of throat cancers. And in case of oral cancers, when there is advanced disease, radiation therapy provides a long-term less recurrence rate when given as adjuvant treatment for the surgery. Another modality of treatment which we can include combinedly is the chemotherapy, targeted therapy, and immunotherapy. These chemotherapy has adjuvant role in initial cancer management when it is curative, and in case of stage 4, when disease has spread to other organs, in those cases, the main treatment is chemotherapy or immunotherapy, but that fact should be conveyed to patient in initial that our treatment of intent is not curative, because at that time we cannot cure. We can prolong their life to some extent. We can give good quality of life compared to no treatment, and they should ask the financial implications of what are the cost of the treatment and then decide accordingly, because in this stage it is the limitation that cure is rarely possible. Sometime in some limited cases when there is some very small tumor or uh, at limited sites, in that we can think of giving curative, but initial treatment is stage 4 is usually palliative treatment. So in these see, we can see that the treatment is very it includes a multimodality management and special skills and planning to give a very good results. So in Narayana, we have all the facilities for like frozen section, advanced care of the treatment, and one of the best of radiation therapy machine also here. So patients should choose the center wisely and their doctors wisely so that they can have proper and good results at that.
Thank you so much. And that's great to hear that if you come in early, then you can get completely cured. I think that is the takeaway message from what you said. The people need to know that they have to identify the lesions, not sit and wait for it to spread and then come in. Because I think the surgeons also want that you get cured and get back with your normal life as soon as possible. So to keep it simple for yourself and for the surgeons, I think you should come in very, very early and ensure that you're completely cured. Thank you, Dr. Yadav. I'll take a few more questions later. Now we have kept our best speaker for the last, Dr. Liu. If you are to look beyond, beyond India, we have been talking of India, the problems here. We would want that you take us to, a journey of what is happening globally. How big is the problem? How are they managing the disease? What is happening with head and neck cancers in other parts of the world? You're on mute, ma'am.
All right. So, yeah, can you hear me now?
Yes.
Great. Yeah. First of all, thank you so much, Ms. Biswas, for having me today here. And it's really an honor to join the distinguished panelists today here. And in a way, I think it's really by luck. Otherwise, I would be happy in the US already, but it's just due to COVID. I'm still in Singapore. I'm going back to US actually in 2 weeks' time. It's really a good opportunity to witness a lot of the effort going on actually in the India to tackle the head and neck cancer problem. And so I'll say from the global perspective, if you look at the global cancer data in 2020, actually head and neck cancer is still one of the leading cause of cancer-related morbidity and mortality is number 7. I'll say that global-wide, definitely, head and neck cancer, it is a serious problem. It's also have a lot of unmet medical need. And I'll say that in the past 5 years, and there are certain significant advancement has been made in managing head and neck cancer patients, in particular as the patients at the recurrent and metastatic state. And once patients move to the recurrent and metastatic state, actually the treatment objective is not for cure, like Dr. Yadav mentioned. It's not, it's beyond cure. The cure actually, it will be the chance will be very, very minimum. And the objective of the treatment is really to prolong the patient's life. And as we know, of course, the earlier stage of the cancer and the earlier treatment, definitely the outcome will be better. And once patient reach the recurrent metastatic state, the survival of a chance, I'll say that is quite sort of slim, and for long-term survival will be very, very slim. And as we look back, in 2008, and that time actually there was one study was published, and that study actually has proved in that the extreme regimen it's a combination of cetuximab plus cisplatin and 5-FU. The extreme regimen actually was considered the standard of treatment and proved and the overall survival benefit in comparison with just cisplatin plus FAU. And that was in 2008. And in the past 15 years, actually, there was no sort of new breakthrough or a further significant advancement in managing patients with recurrent metastatic cancer until 2008, and that's the time actually we have seen a lot of significant advancement in immuno-oncology, and which actually has changed the paradigm for many head and neck cancer patients. So now I would like just to focus on in the first line recurrent metastatic setting, and there are quite a number of checkpoint inhibitors study in the second line and first line setting. And maybe today we'll just focus on the positive study, which is Keynote 48 study. Keynote 48 is a phase 3 clinical trial of first-line pembrolizumab for recurrent and metastatic head and neck squamous cell carcinoma. The objective of this phase 3 study was to investigate the efficacy and safety of pembrolizumab alone or with combination of chemotherapy versus extreme regimen in the recurrent metastatic setting first line. And in Keynote 48, and pembrolizumab has been shown to demonstrate the superior overall survival versus extreme regimen in patients with recurrent metastatic cancer. And just to elaborate a little bit of in the survival benefit here, the data, and in comparison with the control arm, pembrolizumab monotherapy reduced the risk of death by 26% in patients with a PD-L1 expression level tested at the CPS at least 1. And pembrolizumab in combination with chemotherapy reduced the risk of death by 28% in patients regardless of PD-L1 expression status. And this data actually was presented at ESMO 2008, and the comments that, at that time from the society is really as citing a new standard of treatment. And it's after a long-term follow-up, that was data also presented last year, and the benefit of the overall survival is sustained over 48 months. So this is 4 years data. And at 4 years data follow-up cut-off time, the survival rate of patients in the pembro monotherapy arm is 3 times of that comparing in the control arm. And this, we are talking about the patients with PD-L1 expression of CPS is 1 or above 1. Well, the 4-year survival rate of patients in the combination arm is 4 times of that in the control arm. And this group of patients actually is regardless of PD-L1 expression level. I would also like to highlight another advancement and through our clinical programs in the head and neck cancer and its biomarker. Ideally, we know in our clinical practice and therapy should be targeted at patients who are most likely to respond to the patient. And biomarker testing may be a solution as it helps predict which patient will respond to certain treatment. However, there was no established biomarker in head and neck cancer patients management until the PD-L1 assay developed for use with pembrolizumab is validated in the Keynote studies. Knowing that patients' PD-L1 status in terms of the CPS scoring and can help oncologists and the patient make confident and informed treatment decisions. So definitely it's important. And since we have the biomarker to help us to select patient, it's always good that we at the time of diagnosis and to get the biomarker information. So that will be easier when we discuss the treatment regimen with the patient. And international guidelines such as those issued by National Comprehensive Cancer Network or NCCN ASCO and ESMO actually recommends pembrolizumab as a first-line treatment regimen for the appropriate head and neck cancer patients. And of course, definitely, I'll say that IO treatment, it has shown the survival benefit, but it's not that it's without any adverse event or side effects. Just like when we look at Keynote 48 study, and the pembro monotherapy arm, the safety profile and is more favorable compared to the extreme regimen. And in the combination arm, and the safety profile actually is comparable with the extreme regimen. I think many of you are quite familiar with the safety profile of the extreme regimen. So this is more of the latest advancement in the recurrent and metastatic setting. And of course, in the cancer research, and once we have touched bases on the recurrent and metastatic stage, and the next step definitely is to move to earlier lines of treatment. And earlier lines of treatment in head and neck cancer is just referring to the patients who are still eligible for curative treatment, as Dr. Yadav mentioned just now. So now there's actually quite a number of clinical trials and using IO or IO combinations and in the local regionally recurrent setting. And this is LA setting, and we are eagerly waiting for the result and in the LA setting. And I hope that I just in a few minutes I've just highlighted the recent advancement in managing patients with head and neck cancer here.
It's wonderful. I think you have put a lot of it in a nutshell. But at least there's hope. There are things happening, biomarkers coming in. I believe that, things will emerge for treatment where it is more curative. But I think it still stays, as Dr. Yadav said, come in early. I think everybody said that, come in early. That I think is the take-home message for all of us. But thank you so much, Dr. Liu. We have time for questions, and we have some questions in the chat. So I'll start off with the first one. One question that is there, it's to Dr. Gupta. Some people say that my grandfather has been consuming tobacco for 75 years, and he's a healthy 75. So why do I have to quit tobacco?
Very congratulations to his grandfather. He is very lucky, and wish him very long and healthy life. The second point is that we never say, epidemiology doesn't show that each and everyone who uses oral cancer will get tobacco, or each and everyone will die early. In fact, the best study results that are from UK, they show that 50% of smokers, they die early because of smoking. But that also means that 50% of smokers do not die early. They live their sort of normal life. So, if someone is one of those lucky 50%, great, wonderful, congratulations. But there is no way of telling beforehand who is in that lucky 50% and who is in the rest of 50%. So that is why all these studies and messages are important.
Not a good idea to take risk. You never know which side you are in.
Absolutely.
So that I think is the message for us. We also hear that, there is an infection or could be like the human papillomavirus could be implicated as one of the factors. So if I can ask Professor Mehrotra to shed some light on that, can someone be protected by using the HPV vaccine? Does it work? Are oral cancers caused by the virus?
That's a very good question. And the HPV vaccine for cervical cancer now has been recommended as a single dose, and that has confirmation has come from the WHO very recently. And we are also hopeful that the pricing of the HPV vaccine will be reduced as more and more people start taking it, and as well as there is a strong possibility of an Indian vaccine for HPV being released fairly shortly. Coming back to oral cancer or HPV connection, small minority of oral cancers are related to HPV, mainly in the posterior oral cavity, especially of the pharynx, which not in the anterior oral cavity. Most of the cancers which occur in India are of the anterior oral cavity, which are caused primarily by the trio, tobacco, alcohol, and areca nut. In countries where the tobacco use is declining in a big way, especially the Western countries like United States, the prevalence of HPV or human papillomavirus caused posterior oral cavity cancers is actually on the rise. As a matter of fact, the majority of cancers now occurring in that region in the US are related to human papillomavirus. Some countries have already started giving HPV vaccine to boys in addition to girls, especially the first one was Australia, and many others in Scandinavia are following the same trend. It is still early days to see how effective it is. But in addition to the posterior oral cavity, you have penile cancer, anal cancer, and a few others which are related to HPV. It is expected the results will probably be there very shortly. It is expected that in these countries, at least, results will show that boys should also be given human papillomavirus. One aspect is, of course, the cancer. The other aspect is that the people will develop herd immunity and the cervical cancer will also go down because of the boys getting the vaccine. So in a nutshell, results are not completely in, but if you can afford it, if the country has an effective vaccination program, it is probably a good idea going forward to give HPV vaccine both to the boys and girls.
Thank you, sir. Very positive. I have one question for Dr. Yadav. What are the side effects of treatment of head and neck cancers?
As I described already, that rehabilitation is an important aspect of management of oral cancers. So whenever the surgeries are done, the reconstruction is done in such a way that they will be able to have adequate quality of life. Main morbidities of head and neck cancers are related to swallowing, to the speech, and these are because jaw bones or sometimes tongue is involved in the management, and other morbidity may be related to the voice because of involvement of voice box or larynx. So treatment is nowadays is such an advanced stage that it is incorporating the part that these morbidity will be minimized. So sometimes these proper rehabilitation program should not be forgotten in the treatment part. So whenever surgery done, the reconstruction should be done accordingly. And whenever these treatment for throat cancer or voice box is done, the voice rehabilitation should also be done in that way that people will be able to speak properly or will be able to convey their messages. So there are many modalities for that, like tracheoesophageal prosthesis or cleptolarynx, or it's even some patients can be taught esophageal voices. Even without any device, they can communicate properly, and their voice is very clear with the esophageal voices, but that requires a lot of training in that part. So people should have patience in that part and do the advice properly as advised by their treating doctors. Some patients, some patient is involved multimodality treatment. So apart from these, they may have some difficulty in opening in the mouth, which is called as trismus. The patient who are getting treated for the especially part of retromolar tribone. At that part, there are a lot of muscles which are responsible for closing of the mouth. And when after surgery radiation is given to that part, they have a lot of fibrosis and difficulty in opening the mouth. So, but our practice is that we teach the mouth opening exercise since the beginning of the treatment. By that way, they have less morbidity related to that opening of the mouth. Then with the radiation therapy, sometimes there is loss of taste sensation, and they may have difficulty in taking proper taste and decreasing the saliva. So difficulty in taking the food. But these are the problems. With time, these will improve. And with the proper advice, like lot of water and proper mouth hygiene, these will improve with that time. So we can at that time we can say that there are not much morbidity which keep a patient away from taking that treatment. Risk of not getting a treatment is much more, and risk of morbidity is very less compared to the benefit which they achieve by getting the treatment proper.
Thank you. Thank you so much. I have time for one short question for your Professor Mehrotra. Somebody has asked that if they're not consuming tobacco, should they still be going for regular screening?
Yes, I think they should, because tobacco is only one of the risk factors of cancer. And even if you're not taking tobacco, I think it's a great idea. You may be relating yourself to areca nut, you may be taking alcohol, or even without taking any of these substances, there have been cases of oral cancer which have been detected just by opening the mouth. So we suggest that all dentists, all ENT surgeons, and all general practitioners, whenever they see a patient, at least at the yearly, if not at least 2 yearly, if not yearly interval, should actually open the mouth. It hardly takes a few seconds, and if any abnormality is there, which has been persisting for more than 2 weeks, which may or may not have a reason. For example, there could be an ill-fitting denture, which quite often in the elderly, they are not taking any tobacco, or they have a sharp tooth. Even that causes cancer. So to put it in a nutshell, whether you have a known risk factor or not, it is always a good idea to get your mouth opened. And if there's no abnormality, well and good. If there is abnormality, please make sure it is investigated further and it is taken ahead to its appropriate conclusion. I think that's an excellent question. Thank you for asking.
Thank you. There are participants who are very active. Dr. Gupta, one question for you. Someone says that I have tried quitting tobacco for years and I cannot. So what does one do? Give up or continue having tobacco? Do what?
No, I think continue trying, because nobody in the world, I mean, there are very few persons in the world who say that they were able to quit tobacco just on the first try. So keep on trying and take help. Taking help matters a great deal. There is absolutely should be no hesitation. There is no shame in asking for and getting help in quitting tobacco. And as I said, there are lots of help available. Lots of different kinds of intervention, including going up to pharmacological intervention. So please take help from counselor, from the doctor, and there are websites that advise how to quit. So please take help from sources, and I'm sure, and my best wishes are with you, that you will be able to quit.
Thank you so much. I think we have many more questions, but we don't have enough time. So we could take only these few. So with promise to come back with more sessions on cancer prevention and head and neck cancers, I would like to thank each one of you for being with us today. All the speakers, thank you very much. I'm sure you are taking back valuable information to the participants to prevent head and neck cancers. A special thanks to the entire team of ASSOCHAM for making this possible. And now have a great evening, and over to Commander Bali.
Thank you so much. I will just like to end this by we spoke about luck, and I think life is too precious to be just left to luck. As Dr. Prakash was just talking about, please keep making efforts to get into this think of leaving tobacco. I think I started by saying that we couldn't have asked for a better panel than this to discuss this very, very pertinent topic here. So thank you, Dr. Prakash Gupta, Dr. Yan Ping Liu, Professor Ravi Mehrotra, Dr. Kaushal Yadav, and our gracious host, Sutapa. And as I said, these are knowledge sharing discussions. These are the ones which are sort of fountainheads of what can be done. These are complex issues, but I'm sure there's always a first step, and I think those steps have been taken many, many years back. So thank you so much, and have a great evening, everyone. Thank you so much.
Thank you. Thank you very much.
Thank you. Thank you, everybody.
Thank you.
Thank you very much.
Thank you.